Dear participants, Assalamu alaikum, good evening. It's a pleasure that Bangladesh Rheumatology Society has organized this monthly webinar on hematological manifestations of SLE and its management. Many of you know our society is organizing this kind of webinar for the last several months. Our aim is to encourage our young rheumatologists to deliver lectures. Today we have two speakers, and in every session we try to include one overseas rheumatology colleague. And today Dr. Bineet Vaidya from Kathmandu, Nepal has joined with us as a panelist. Welcome, Dr. Bineet. Now I would like to request Dr. Ahmedullah to moderate the scientific session. Dr. Ahmed, please.
And as you heard, that today's webinar is going to be presented by our two speakers, and the topic is hematological manifestation of SLE. The webinar will be chaired by Professor Syed Atikul Haq. He is President of APLA and President of Bangladesh Rheumatology Society. And our two speakers are Dr. ATM Tanvir Hassan. He is an assistant professor from Anaemia Medical College, and Dr. Mohammad Asadul Islam, registered Department of Medicine, Rajshahi Medical College. Our first speaker is Dr. Asadul Islam. He will speak on anemia and its management in SLE. And second speaker is Dr. ATM Tanvir Hassan. Dear audience,
আচ্ছা, আহমেদকে কিন্তু শোনা যাচ্ছে না। আহমেদ মিউট হলে চলবে না।
আহমেদ ভাই আনমিউট করেন। আহমেদ ভাই আপনি আনমিউট করেন। আহমেদ ভাই শোনা যাচ্ছে না।
Rheumatology sorry, our panel of experts are Major retired Dr. Syed Jamil Abdal. Dr. Dr. Jamil Abdal is a rheumatologist from BSMMU. Dr. Mohammad Abu Shahin, Associate Professor of the Department of Rheumatology, BSMMU. Dr. Shami Ahmed, Associate Professor of Department of Rheumatology, BSMMU. Dr. Bineet Vaidya, Chairman, Head of Rheumatology, National Center for Rheumatic Diseases, Nepal. Professor Mohammad Nazrul Islam, Chairman, Department of Rheumatology, BSMMU. And Professor Minhaj Rahim Chaudhary, Professor of Rheumatology, BSMMU, and Secretary General, Bangladesh Rheumatology Society. And dear audience, I will invite you to this webinar. I first like to request Dr. Mohammad Asadul Islam to deliver his speech. Dr. Asad, please. Dr. Asad, The topic of Dr. Asadul Islam is anemia and its management in systemic lupus erythematosus.
Assalamu alaikum, respected chairperson, respected teachers and panelists, dear colleagues and audience. I am Dr. Muhammad Asadul Islam, rheumatologist working in Russian Medical College Hospital. I am going to present today. My topic is anemia and its management in SLE. The major hematologic abnormalities in SLE are anemia, leukopenia, thrombocytopenia, lymphadenopathy, and splenomegaly. And causes of these hematologic abnormalities in SLE may be itself from SLE manifestation or due to concomitant other diseases, or these manifestations may be the result of the consequence of the treatment of the SLE. Now, anemia, it is the most common hematologic abnormality in SLE, which affects more than half of the SLE patients. And the causes of the anemia in SLE patients are inflammation or anemia of chronic disease, iron deficiency anemia, that is due to GI blood loss, or due to medications such as cyclophosphamide, mycophenolate mofetil, azathioprine, methotrexate, etc. Autoimmune hemolysis or autoimmune hemolytic anemia, autoimmune destruction of hematopoietic cells in the bone marrow may be the other important cause. Hypersplenism, renal insufficiency, aplastic anemia, myelofibrosis, hemophagocytic lymphohistiocytosis, myelodysplastic syndrome may be the other causes of anemia in SLE. Now, anemia of chronic disease or anemia of inflammation in SLE. This is the most common type of anemia in SLE, which is usually manifest as mild anemia, and morphologically it is normocytic normochromic anemia, where reticulocyte count usually low, and their iron stores in these cases are adequate, and there are no specific laboratory tests to detect anemia of inflammation in these patients, and we diagnose it by exclusion of other causes or other features. In anemia of inflammation or anemia of chronic disease, in SLE patients, there are interleukin-6 which are released from inflammatory cells, which go into liver, where it stimulates to produce hepcidin, and this hepcidin goes into the enterocyte of the gastrointestinal epithelium, and in the enterocyte, where it inhibit or abnormality produced in the ferroportin, which is usually involved in the iron transportation and trafficking, and hepcidin causes hindrance to prevent iron absorption, and also prevents iron incorporation into RBC. And treatment of this anemia of inflammation or anemia of chronic disease are treatment of the underlying condition, such as different disease activity of diseases, or in this SLE patients, we have to treat SLE appropriately. And if patient is symptomatic, then erythropoiesis stimulating agents may be an option, but there is no clinical trial to evaluate the use of these erythropoietic stimulating agents in SLE patients. Now, iron deficiency anemia in SLE. Iron deficiency anemia, we all know that there are patient may present with undue fatigue, pica, that is ingestion of different abnormal materials such as sand or land or etc. And pagophagia, ice craving, restless leg syndrome, celiac disease, heavy menses, or GI bleeding. When we examine this patient, we can find pallor, brittle skin, fingernail changes, cheliosis, occult blood in the stool. when we find complete blood count of this patient, there is anemia, low RBC count, low reticulocyte count, and there is microcytic hypochromic anemia, but maybe normocytic, and there is usually platelet count is usually high. Causes of this iron deficiency anemia usually blood loss, maybe due to menorrhagia or GI blood loss, and this is usually microcytic hypochromic anemia, inappropriately low reticulocyte count, serum ferritin and or transferrin saturations are low, transferrin total iron binding capacity ratio is high. Ferritin is an acute phase reactant and may not accurately reflect iron stores in SLE. Concomitant anemia of chronic disease and iron deficiency anemia is a common occurrence in SLE patients where ferritin usually not more than 100 nanogram per ml. Soluble transferrin receptor increased in this patient. Soluble transferrin receptor log ferritin ratio in anemia of chronic disease less than 1, and if this ratio more than 2, that indicate iron deficiency anemia or concomitant present of iron deficiency anemia and anemia of chronic disease. RBC protoporphyrin and RBC zinc protoporphyrin increased, reticulocyte hemoglobin content decreased in this patient, and bone marrow iron store, iron stain if we done, there is decreased or absent bone marrow iron. Further, we can evaluate by this flow chart where there is, if serum ferritin less than 13 nanogram per ml, then it is iron deficiency anemia. And if it is more than 30, then we should find transferrin saturation. And if this transferrin saturation become low, that is, if transferrin saturation less than 10%, then almost confirmatory diagnosis of iron deficiency anemia. Somebody says it is less than 16%, we can call iron deficiency anemia. And if this iron deficiency anemia concomitant with anemia of chronic disease, then this transferrin saturation may become less than 19%. How can we treat this iron deficiency anemia? Identification and treatment of the source of bleeding, that is eradication of H. pylori infection, appropriate management for NSAID induced or NSAID plus glucocorticoid induced peptic ulcer bleeding. Then dietary iron should be adequate. Treatment of the malabsorption, oral and or IV iron, and RBC transfusion. Now, when we can use oral iron, if there is uncomplicated iron deficiency anemia, and this oral iron are readily available, generally effective, inexpensive and safe. Once daily and alternate days for 6 weeks to 6 months according to severity. Most patients develop GI intolerance. IV iron, when we use IV iron, if there is lack of response or intolerance or inability to adhere the oral iron, late second and third trimester of pregnancy, we can use this IV iron. If we are planning for surgery within next 2 months, then we can use IV iron. And if the patients have inflammatory bowel disease, gastrectomy, bariatric surgery, chronic kidney disease on dialysis, in this situation, we can use IV iron instead of oral iron. When we can use red blood cell transfusion. If patients have severe anemia, that is hemoglobin less than 7 gram per DL, or patients having symptoms of anemia or having hemodynamic compromise or cardiac ischemia, or patients have life-threatening anemia. In this situation, we can use or we should use RBC transfusion. Now, anemia due to drug-induced bone marrow suppression, and the drugs we commonly use in SLE patients like hydroxychloroquine, mycophenolate mofetil, cyclophosphamide, and these drugs may cause bone marrow suppression and causing anemia. Now, the commonly encountered type of anemia in SLE patients is autoimmune hemolytic anemia. About 10% of SLE patients have autoimmune hemolytic anemia, and this anemia may develop even few years before the development of SLE, or it may be a presenting features, or it may be occur after the diagnosis of SLE. And in the peripheral blood film, we will found that there is spherocyte. In these cases, there is increased reticulocyte count, indirect bilirubin, and lactate dehydrogenase. And there will be low serum heptoglobin, direct antiglobin or direct Coombs test positive in 97% cases. Association of this autoimmune hemolytic anemia with renal disease, neurologic disease, with seizure, serositis, and or antiphospholipid antibodies are reported. Rarely, this anemia associated with idiopathic thrombocytopenic purpura, and when concomitant presence autoimmune hemolytic anemia with idiopathic thrombocytopenic purpura, this is called Evans syndrome. Warm or cold autoimmune hemolysis may occur in this SLE patient. Positive direct Coombs test does not always have hemolysis. How will we treat the autoimmune hemolytic anemia in SLE patient? There are various options to treat. First line agents are glucocorticoid in the form of oral prednisolone and or IV methylprednisolone, and sometimes rituximab may be the first line option. Second line agents are splenectomy, immunosuppressive therapy or cytotoxic drugs such as azathioprine, mycophenolate mofetil, cyclosporine, rituximab, danazol, cyclophosphamide, alemtuzumab, vincristine. Now, the main or cornerstone agent to treat autoimmune hemolytic anemia is prednisolone, and there is usually high dose prednisolone is required, and tapering of this prednisolone is a very important issue in these patients, and we should treat with 1 to 1.5 milligram per kg per day prednisolone to treat autoimmune hemolytic anemia. And if there is severe hemolysis, we can start with IV methylprednisolone 250 to 1000 milligram per day for 1 to 3 days, followed by oral prednisolone 1 to 1.5 milligram per kg. And if there is severe or symptomatic anemia, we may use this prednisolone with rituximab. And this oral prednisolone, we should continue 1 to 3 weeks. And after 1 to 3 weeks, we follow the patients with CBC count and other parameters. And if the hemoglobin more than 10 gram per deciliter, then the dose should be continued another 1 week. And if the initial agent only glucocorticoid, and with this glucocorticoid, if there is no response within 2 weeks, then we can start rituximab with or without mycophenolate mofetil. And if the patient respond within 1 to 3 weeks and then continue the dose another 1 week, and then tapering should be done, and within 2 weeks we should taper into 20 milligram per day, and this 20 milligram should be maintained for 4 weeks. And if remission persists with this 20 milligram, then we reduce the dose with 20 milligram per day, alternate with 10 milligram per day, and this dosing schedule should be continued for another 4 weeks. And if remission persists with this regimen, then we can reduce the prednisolone dose into 20 milligram in every other day. And if remission persists with this 20 milligram every other day, then we can reduce the dose into 10 milligram per day in alternate day. And tapering will be continued if there is heptoglobin will be improved, and there is low LDH and reticulocyte count less than 1 lakh per microliter. Glucocorticoid, when we discontinue the prednisolone or glucocorticoid, if there is normalization of hemoglobin, heptoglobin, LDH, and reticulocyte count. And after discontinuation, we should follow the patients to see the recurrence up to following a few months. When we should add immunosuppressive therapy in the treatment of autoimmune hemolytic anemia. If there is no response to prednisolone after 2 to 3 weeks of treatment, If there is relapse following discontinuation of glucocorticoid, if the prednisolone dose needed to maintain remission more than 15 milligram per day, EULAR 2019 recommends combination of moderate to high dose glucocorticoid and immunosuppressive agents from beginning to facilitate glucocorticoid sparing. So, if anyone want to start steroid sparing agents from the initial part of the treatment, then it is also recommended by EULAR 2019. How we can monitor this autoimmune hemolytic anemia during treatment? The tools can be used: complete blood count, reticulocyte count, LDH, and other hemolysis panels such as bilirubin and other parameters. And frequency of this monitoring should be: if patient is transfusion dependent, then 1 to 2 weeks, 2 times per week. And if patient transfusion independent, then weekly can be monitored. If there is hemoglobin stable, monitoring interval can be extended. When rituximab is indicated in a patient with autoimmune hemolytic anemia in SLE, rituximab may be used as a first-line therapy in autoimmune hemolytic anemia if there is severe or symptomatic anemia along with glucocorticoid. And it can be used as second-line therapy if the glucocorticoid is failed, or splenectomy or other immunosuppressive or cytotoxic agents, or patient refused to do splenectomy. And rituximab dose should be 375 milligram per meter square IV weekly for 4 dose, or 100 milligram per week for 4 dose. When we should do splenectomy in this autoimmune hemolytic anemia patient? Previously, it was used as second line before immunosuppressive or cytotoxic drugs. And when it is indicated, if there is no response or relapse after immunosuppressive or rituximab. Efficiency of splenectomy: 2/3 to 3/4 patient within 2 to 3 weeks, short-term improvement. 50% of patients achieve remission, required less glucocorticoid than before. 20% will be cured. Up to 30% patient will relapse. When IVIG is indicated as a part of initial therapy in very severe disease or very high dose, twice more than the usual dose, 1000 milligram per kg per day IV for 5 days. Occasionally effective. 40% of patients of autoimmune hemolytic anemia refractory to conventional therapy with prednisolone and splenectomy. The effect is usually transient. Repeated course of IVIG is given every 3 weeks after. When red blood cell transfusion is indicated in autoimmune hemolytic anemia, it is required when there is severe fall of hemoglobin. Testing of compatibility should be done before transfusion. Presence of pan-reacting antibody or alloantibodies because of pregnancy or previous transfusion. Massive transfusion reaction may be happen, but most patients will tolerate even serologically incompatible blood. Another cause of anemia in SLE patients is pure red cell aplasia. Pure red cell aplasia is a rare form of bone marrow suppression. Antibodies against developing RBC precursors interfere with the productions of RBC. Severe anemia and very low reticulocyte count is usually found. Treatment can be done with glucocorticoid plus cyclophosphamide or cyclosporine. Transfusions may be required. And another important cause of anemia in SLE patients when it is associated with antiphospholipid antibody syndrome is microangiopathic hemolytic anemia. And there is mechanical shearing of RBC, and there is spherocyte can be found in peripheral blood film. And causes of this MAHA are thrombotic thrombocytopenic purpura, when we can be treated with plasma exchange. Drug-induced thrombotic microangiopathy can be treated with drug discontinuation, and disseminated intravascular coagulation DIC we can treat with underlying cause and other associated treatment. Catastrophic antiphospholipid syndrome we can be used with anticoagulation and glucocorticoid. Pernicious anemia can also be found in SLE patients, and we all know there is macrocytic anemia, and there is hypersegmented neutrophil can be found in peripheral blood film, associated mild cytopenia, and there may be low vitamin B12, low serum vitamin B12, and antibody to parietal cell or intrinsic factor may be found. And these are about anemia in SLE patients. And I acknowledge Professor Dr. Minhas Rahim Chaudhary, Dr. Najib Rahman, and Dr. Rizal Karim, rheumatologist. Thank you all. Thank you for patience hearing.
Thank you, Dr. Asad. It's a very good presentation. Dear audience, if you have any question, please put it in the chat box. Now, I like to request Dr. ATM Tanvir Hassan to deliver his speech. Dr. Tanvir, please.
Assalamu alaikum, everyone. I am Dr. ATM Tanvir Hassan, currently working as an associate professor of rheumatology at Anaemia College and Hospital. Today, I am going to talk about hematologic manifestations of SLE, WBC, and platelet abnormalities and their management. So I welcome you all to the discussion. So I would like to give an outline of my discussion at first. I will talk about WBC abnormalities followed by platelet abnormalities. And as you all know that platelets play a very important role in hemostasis in conjunction with clotting factors in blood. I will also discuss the clotting factor abnormalities encountered in SLE very briefly. So first of all, what are the WBC abnormalities we commonly encounter in patients with SLE? These are leukopenia, neutropenia, neutrophil dysfunction, lymphopenia, neutrophilic leukocytosis, and lymphocytosis. So leukopenia, that is less than 4,000, WBC count less than 4,000 per cubic millimeter of blood, affects about 50% patients with SLE. So it's quite common. But severe leukopenia, that is total leukocyte count less than 1,000 per microliter or cubic millimeter, affects only about 20% patients with SLE. So since most of WBCs are neutrophils, leukopenia typically reflects neutropenia. So neutropenia means absolute neutrophil count less than 1,500 per microliter. Important causes include immune-mediated, that is autoimmune neutropenia, infections, medications, for example, those drugs that are used in SLE, that is immunosuppressive drugs, hypersplenism, and ethnic neutropenia. So I think all of these terms are very familiar, but the term that I mentioned at last is ethnic neutropenia has some importance. I will not discuss it later, so I am taking the chance to discuss it just now in very briefly. Actually, SLE is very common in the people with Afro-Caribbean descent, and in the same population, there is a benign form of neutropenia that is encountered, which is called ethnic neutropenia, that has that does not create any problem, but it can sometimes make a confusion in dealing with SLE patients. So moderate to severe neutropenia, which is defined as an absolute neutrophil count less than 1,000 per microliter, may be accompanied by infections as a cause or consequence. Other cytopenias, that is anemia and thrombocytopenia, and history of neuropsychiatric involvement. That is, neutropenia may be associated with neuropsychiatric lupus. So, as you know, there are multiple disorders involved with these two cell lines, that is WBCs and platelets. So I will try to touch every type of problem that we encounter and their treatment briefly to save time. So what would we do when we are going to treat autoimmune neutropenia? So expectant management is the rule, and treatment of concomitant organ manifestations is the key. So we can use myeloid growth factors only when absolute neutrophil count is 500 per microliter and there is concomitant infection, because it should be used sparingly because of its association with lupus flares, and there is a risk of development of leukocytoclastic vasculitis following its use. So the minimum dose of GCSF should be used to maintain the absolute neutrophil count of more than or equal to 1000 per microliter. Other than neutropenia, there may be neutrophil dysfunction, and this may be due to autoimmunity, that is due to SLE itself, or drugs, particularly glucocorticoids. And the treatment is directed at the cause, as always. So you have to treat SLE and other concomitant organ manifestations. There is no specific treatment directed at neutrophil dysfunction due to SLE. And the regarding drugs, you have to either taper the drugs or withdraw the drugs according to the clinical context. So lymphopenia. It is defined as an absolute lymphocyte count less than 1000 per microliter, and it particularly involves the regulatory T cells, observed in 20 to 75% of patients, and it's observed particularly during active disease. It may be clinically silent, or it may be associated with increased risk of infections, particularly when the lymphocyte count is less than 300 to 500 per microliter. So the causes which are commonly we encountered in clinical practice are immune mediated, that is autoimmune lymphopenia due to SLE itself, viral infections, and immunosuppressive drugs. Just in common with autoimmune neutropenia, the expected management is the rule while dealing with autoimmune lymphopenia. And we must treat the concomitant organ manifestations. In rare cases, when there is severe lymphopenia, that is, which is variably defined as less than 300 to 500 per microliter, it may be appropriate to use pneumocystis prophylaxis, pneumocystis pneumonia prophylaxis. But there is a lack of high quality data to support this approach, and we can use cotrimoxazole under these circumstances if needed. So what about neutrophilic leukocytosis? It is defined as an absolute neutrophil count. It will be more than 7,500 per microliter. Important causes include infections and glucocorticoids and disease activity, that is SLE. So SLE itself can lead to neutropenia and also neutrophilic leukocytosis. So how can we differentiate between among these three etiologies or causes? So it's easy most of the times. For example, if there is infections, we might get other than clinical features, we might get a left shift in the peripheral blood film, that is immature forms of neutrophil, immature forms of the granulocytes will be released in the blood, and when there will be neutrophilic leukocytosis due to glucocorticoids, we expect concomitant lymphopenia and eosinopenia. When it is due to disease activity of SLE, then other organ manifestations are usually encountered. So these are few key points by which we can differentiate among these three causes. So now I would like to discuss lymphocytosis. The important causes include infections and lymphoid malignancies. You can note here that SLE is absent or missing from the list. So SLE does not cause lymphocytosis. It might cause neutrophilic lymphocytosis, but it doesn't cause lymphocytosis. So how can we differentiate? So the first of all, you have to assess the patient clinically, and after that we can go through some investigations. For example, atypical lymphocytosis is more in favor of viral infections, which is defined as more than if atypical lymphocytes account for more than 20% of mononuclear cells in blood, it is known as atypical lymphocytosis, which is more suggestive of viral infections. And if lymphocytosis is unexplained, we can use flow cytometry, which can show clonality in lymphoid malignancies. And in other cases, there will be polyclonal lymphocytosis. So another interesting issue is lymphadenopathy, which is common, which can occur in infections. In our country, it is the most common cause. Then secondary to lupus, which is called lupus lymphadenitis, and also lymphoproliferative disorders. As you know that lymphoma and chronic lymphocytic leukemia is more common in SLE than in the general population. So we have to keep these causes in mind as well. So differentiation is, as always, by means of clinical features and also laboratory clues. Moreover, we might sometimes need biopsy and also sometimes flow cytometry. So I would like to mention some key features of lupus lymphadenitis, so that it becomes easy for us to identify the pattern of lymph node involvement. Lymph nodes are typically soft, non-tender, and discrete in lupus lymphadenitis, and they vary in size from 0.5 to several centimeters, and they are usually detected in the cervical, axillary, and inguinal areas. So it actually lupus lymphadenitis usually spares mediastinal lymph nodes, which is usually involved in lymphoma, particularly Hodgkin's lymphoma. And this is frequently noted at the time of onset of disease or during exacerbations. And biopsies reveal areas of follicular hyperplasia and necrosis. Hematoxylin bodies are highly suggestive but rarely found. And there is a very good response of this lymphadenitis to prednisolone, 20 to 40 milligrams per day. That results in a marked decrease in size of the lymph nodes, but this is less likely in patients with lymphoma and highly unlikely in a patient with metastasis or infection. However, this approach should not be used primarily to differentiate between these features. We have to diagnose the patient at first, and then we can proceed to this step that can strengthen our or consolidate our diagnosis. And now I'm moving on to platelet abnormalities. So there may be thrombocytopenia, there may be thrombasthenia, and thrombocytosis. So there are multiple causes of thrombocytopenia. So I will discuss this one by one. Mild thrombocytopenia is defined as platelet count 100,000 to 150,000 per microliter, and encountered in 25 to 50% of patients with SLE. And moderate to severe thrombocytopenia is encountered in approximately 10% patients. The important causes include immune thrombocytopenia, which is abbreviated as ITP, drug-induced thrombocytopenia, hypersplenism, antiphospholipid antibody syndrome, and thrombotic microangiopathies, the causes of which include catastrophic antiphospholipid antibody syndrome, thrombotic thrombocytopenic purpura, drug-induced thrombotic microangiopathies, and disseminated intravascular coagulation. So first of all, I would like to discuss immune thrombocytopenia in details, because it's the most common cause of thrombocytopenia in patients with SLE. It may present prior to the development of SLE as a chronic complication or acutely during a disease flare. if it precedes the diagnosis of SLE, it may do so by many years. So the patient may present with ITP at first and remain so for many years, and then the full-blown SLE might develop. And 3 to 15% of patients with apparently isolated immune thrombocytopenia develop SLE later in life. Severe bleeding is experienced by only a minority of patients. So what are the investigations that we need to do when we encounter a patient with immune thrombocytopenia? Thrombocytopenia. When a patient with SLE presents with thrombocytopenia, we can advise complete blood count with erythrocyte sedimentation rate, peripheral blood film, CRP, liver function test, renal function test, urinary, abdominal ultrasonography to look for the evidence of liver disease and splenomegaly, coagulation profile, antiphospholipid antibodies, and others as necessary, because this list is not exhaustive. Because depending on the clinical features of the patient, other investigations may be added. For example, bone marrow study may be required. We might need to assess serum vitamin B12 and folic acid level, because these are also causes of multiple cell line abnormalities. So this is just a preliminary list. Sometimes we even have to exclude some investigations from here, because if we clinically suspect a particular etiology very strongly, then we might also omit some of the tests mentioned here. So it is just an idea of what to do. And one interesting point is that although immune thrombocytopenia in SLE is due to formation of antiplatelet antibodies, we do not usually measure these antibodies when a patient presents with ITP, because these are neither sensitive nor specific. And so what are the principles of treatment of ITP in SLE? First of all, I would like to discuss the indications of platelet transfusions. These are given only when clinically significant bleeding is encountered, and to prevent bleeding associated with certain invasive procedures or surgery, and when platelet count is less than 10 to 20,000 per microliter, which poses the patient at a high risk of spontaneous bleeding, especially intracerebral hemorrhage. So immunosuppressive therapy is indicated as per EULAR 2019 guideline for significant lupus thrombocytopenia defined as less than 30,000 per microliter. Before going into further discussion, I would like to mention that there's a wide heterogeneity of treatment approaches to thrombocytopenia. In this discussion, I have tried to stick to the recommendations made by EULAR to make it easy. First line therapy consists of glucocorticoid, and this is also the latest recommendation. There's also a reason. The first line therapy consists of glucocorticoid plus an steroid sparing agent. Any one of azathioprine or mycophenolate mofetil or cyclosporine can be used. And which one to be used depends on which organ manifestations other than thrombocytopenia is actually there in that patient. So the choice will be highly individualized. So sometimes we also have to administer pulse methylprednisolone before we give oral prednisolone. 500 it has to be given when there is critical or severe bleeding, and the dose is 500 milligrams per day IV for 3 days, and it should be followed by oral prednisolone. The dose of prednisolone is 0.5 to 1 milligram per kg body weight for 2 weeks, followed by tapering according to response. So one might ask when to use 0.5 milligram per kg body weight and when to use 0.75 to 1 milligram per kg body weight. If we use methylprednisolone at first, then it's better to use oral prednisolone 0.5 milligram per kg. I mean, start with oral prednisolone 0.5 milligram per kg to reduce exposure to steroid as per British Society of Rheumatology guideline on SLE. But if we don't use pulse methylprednisolone, it's better to start with 0.75 to 1 milligram per kg body weight. So actually, there is no established glucocorticoid tapering scheme in this area. But there is a common approach, which is usually followed. Glucocorticoid is usually tapered over 1 week if there is failure to achieve a total platelet count of more than 50,000 per microliter after 2 weeks of treatment. And this is also the definition of glucocorticoid failure to treat immune thrombocytopenia. But if glucocorticoid, prednisolone, succeeds in raising the platelet count to more than 50,000 per microliter after 2 weeks, tapering should be slow. It should be tapered over at least 6 weeks, but that is not universal. We might, depending on the patient's, monitoring of platelets, total platelet count, we might need to taper it more slowly. And intravenous immunoglobulin is sometimes used as the first line instead of glucocorticoid and a steroid-sparing agent if there is a need to raise the platelet count very rapidly, such as for an invasive procedure. And otherwise, we usually choose glucocorticoid and a steroid-sparing agent together. So what about our second line option? If the patient does not respond to prednisolone after a trial of 2 weeks, then we have to switch to another agent, which is usually rituximab. But cyclophosphamide may be an alternative, especially in the context of our country where many people cannot afford rituximab. And if there is relapse, while patient is already receiving a steroid-sparing agent, and if the patient relapses, then we have to switch to rituximab. And if it is not possible to give the patient rituximab, cyclophosphamide has to be given. And interestingly, in EULAR 2029 guidelines, splenectomy has not been given that much of importance. And they have mentioned that thrombopoietin agonists, for example, N-thrombopac, which is available in our country now, and splenectomy should be reserved as last options. Why? Because if you want to give a thrombopoietin receptor agonist, it's not going to control the disease activity. It's just going to, stimulate the thrombopoietin receptor and, maintain production of the platelets. But it cannot actually control the disease activity. So it's not actually a lasting solution. And regarding splenectomy, there are controversies actually, because there is conflicting evidence of durability of response. Some studies show that it's equivalent, its effect in patients with SLE having ITP and patients without SLE having ITP are similar. But some studies show that it is less effective in patients with SLE. And also, there is a very high risk of serious infections and also cutaneous vasculitis following splenectomy. So that's why splenectomy is no longer a very suitable option nowadays. We have rituximab, we have other drugs, so we would like to choose those drugs instead of splenectomy unless the patient is dying. And now I would like to move on to drug-induced thrombocytopenia. It can be due to different causes. For example, drug-induced immune thrombocytopenia, because drugs can trigger formation of autoantibodies, then which can cross-react with platelets. It can be due to myelosuppression. It can be due to heparin-induced thrombocytopenia. You know that if a patient with SLE has secondary antiphospholipid antibody syndrome, you might need to use heparin, which sometimes can give rise to heparin-induced thrombocytopenia. And another issue, which is interesting, especially in the context of the current pandemic, where Johnson & Johnson and Oxford AstraZeneca vaccine are being used, which can give rise to vaccine-induced prothrombotic immune thrombocytopenia. And that patients with connective tissue disease should get preference in getting vaccines. So some of the patients might develop vaccine-induced prothrombotic immune thrombocytopenia, although it's extremely rare. And now I would like to discuss, so that's all about my discussion on drug-induced thrombocytopenia. Now I'm switching to hypersplenism. It is not common, but it can occur in SLE because there is immune hyperplasia of spleen. in SLE. So sometimes there may be mild to moderate splenomegaly. Usually it is insignificant. Usually, from the clinical point of view, total platelet count is usually 60,000, between 60,000 and 150,000 per microliter, and it may be accompanied by mild anemia and or mild leukopenia. So sometimes it will, create some confusion with ITP, because in chronic ITP, that is a manifestation of SLE itself, can sometimes give rise to splenomegaly. So hypersplenism, also there is splenomegaly in hypersplenism. So how to differentiate this? There is a way, an indium leveled autologous platelet scanning with ILAPS using indium 111 as a radioactive element, shows reduced platelet recovery and normal platelet lifespan. The key point is the platelet lifespan will be normal, because in hypersplenism there will simply be pulling of platelets, not destruction. But in case of ITP, there will be destruction. So in ITP, there will be reduced platelet recovery and reduced platelet lifespan. In hypersplenism, there will be reduced platelet recovery and a normal platelet lifespan. The treatment is usually expected, because as you know that it causes mild to moderate thrombocytopenia, which usually doesn't cause any problem. But in severe cases, we might need to go for splenic artery embolization or splenectomy. And antiphospholipid antibody syndrome is sometimes associated with thrombocytopenia, although it is mild, and it is due to binding of antiphospholipids antibodies to platelet-associated phospholipids. So one point has to be noted here, that when there is ITP, the antibodies are directed against platelet glycoproteins and HLA antigens on the platelet surfaces. But when it is antiphospholipid antibody syndrome, these antibodies will bind to platelet-associated phospholipids. So whatever it is, there will be antibody binding in both of the cases and result in thrombocytopenia. But here, the thrombocytopenia is usually mild and does not require treatment. But there is an exception, which which I will touch later, and the mechanism there is entirely different. It's catastrophic antiphospholipid antibody syndrome. There will be massive platelet consumption, and that's why there might be severe thrombocytopenia. There is an exception where there is severe thrombocytopenia in the background of antiphospholipid antibody syndrome in a totally different mechanism, and that is called catastrophic APS. So this is it. There is widespread thrombosis, as I said. So there is platelet consumption, and there is thrombocytopenia, just like DAC. And the treatment here is, I'm telling it very shortly, because there are multiple disorders, so it's not possible for me to discuss every treatment of each and every disorder in details. So we must start anticoagulation and glucocorticoid. IVIG may be required with or without plasma exchange when the patient does not respond to glucocorticoid and anticoagulation. So catastrophic APS is a thrombotic microangiopathy. So there may be other thrombotic microangiopathy in SLE. For example, thrombocytopenic purpura due to autoimmune inhibition of ADAMTS13 activity in SLE. And the first-line treatment consists of plasma exchange. Then we drug-induced thrombotic microangiopathy. But the drugs usually used for SLE do not cause thrombotic microangiopathies. But the patients with SLE have increased risk of cardiovascular disease, for which they might get clopidogrel, which is cause of drug-induced thrombotic microangiopathy. There may be they may get other drugs for other reasons, which might lead to TMA. And the treatment is actually drug discontinuation, and we have to identify the drug and discontinue it. And the patient may develop disseminated intravascular coagulation. We have to find out the underlying cause, which may be infection, malignancy, pregnancy complication, etc. So the cause needs to be treated in those areas. In most of the cases, we have to identify the cause and we have to treat the cause. So another point is that, which is not common. It's not common, but it needs it requires mention. It is acquired thrombasthenia. It may be caused by an autoantibody against glycoprotein 2B3A. Interestingly, autoantibodies against glycoprotein 2B3A can cause thrombocytopenia and also rarely thrombasthenia instead of thrombocytopenia. So according to, it's not very common, but it can encounter. In those cases, patient will come with present with bleeding tendencies, but there will be normal platelet count, normal clotting time, but there will be raised bleeding time. So methotrexate 25 milligram per week has been reported to be successful in case report in the parenteral route. Now I'm going to discuss thrombocytosis, platelet count more than 4 lakh per cubic millimeter. It may be due to disease activity that is secondary to inflammation. There is reactive thrombocytosis, also infections. It may be due to iron deficiency, as Dr. Asad discussed, which is common in SLE patients with SLE. From acute blood loss, for example, from GI bleeding, which can also occur in SLE for various causes, and also hyposplenism, which is also known as autosplenectomy, that can occur in SLE. Usually, it is mediated by this hyposplenism in SLE is mediated by antiphospholipids. So, and in those cases, we might get Howell-Jolly bodies, target cells, phenocytes, any one of these, or in combination in the peripheral blood film. So, one interesting point is here that antiphospholipid antibody syndrome can cause thrombocytopenia. It can also cause thrombocytosis. It can cause thrombocytopenia by binding to platelet phospholipids. It can cause thrombocytosis by causing hyposplenism. So Dr. Asad described RBC line abnormalities. I have so far described, WBC and platelet abnormalities, but in SLE, these things can occur in combination. So I'm going to, discuss, multiple cytopenias, the context of multiple cytopenias in brief. So there may be multiple autoimmune cytopenias. For example, autoimmune neutropenia, autoimmune lymphopenia, autoimmune, ITP, immune thrombocytopenia. One well-known example is presence of autoimmune hemolytic anemia and immune thrombocytopenia in combination, which is known as Evans syndrome. Although this condition is not restricted to SLE, it can occur as an independent pathology or idiopathic. It may be idiopathic as well. Thrombotic thrombocytopenic purpura can give rise to microangiopathic hemolytic anemia and thrombocytopenia. Catastrophic APS that can also lead to microangiopathic hemolytic anemia and thrombocytopenia. In autoimmune myelofibrosis, there may be pancytopenia, and most important and very importantly, macrophage activation syndrome can give rise to pancytopenia. So, immune-mediated multiple cytopenias are treated as per principles of treatment of individual cytopenias. So I'm not discussing this in details. Autoimmune myelofibrosis is not common and it's not associated with JAK mutations as encountered in primary myelofibrosis. It is treated with steroid with or without mycophenolate mofetil. Sometimes we might need to use intravenous immunoglobulin. And macrophage activation syndrome, which is defined as hemophagocytic lymphohistiocytosis occurring in the setting of a rheumatic disorder. Initially, it is treated in line with the underlying flare. When there is macrophage activation syndrome, we should not jump to HLH protocol in patients with SLE. We have to try to, treat the underlying flare at first. But if the patient is refractory, MAS is refractory to the treatment of flare, underlying flare, then we have to switch to or add the treatment of drugs mentioned in HLH 94 protocol, that is dexamethasone with etoposide, and in case of nervous system involvement, intrathecal methotrexate and hydrocortisone will be added. And now I'm close to the end of my discussion. I'm going to discuss the clotting abnormalities, which very briefly, but it's quite interesting. Antiphospholipid antibody syndrome, which can give rise to venous thrombosis, arterial thrombosis, and adverse pregnancy outcomes, and it is to be treated with anticoagulation. But other than thrombotic tendency, there may be bleeding tendency in SLE due to clotting factor, clotting diathesis. So there may be formation of autoantibodies against different clotting factors like factor 8, factor 2, factor 11, factor 13, and also one Willebrand factor, resulting in increased bleeding tendency of variable severity. So SLE, interestingly, is a recognized cause of acquired hemophilia and acquired von Willebrand syndrome. So treatment of antiphospholipid antibody syndrome requires anticoagulation, as I discussed, and treatment of other disorders, that is those disorders leading to increased bleeding tendency due to clotting factor inhibitors in blood in the form of autoantibodies, consists of control of active bleeding with there are multiple options. For example, fresh frozen plasma, clotting factor concentrates, von Willebrand factor concentrate, etc. And elimination of inhibitors by immunosuppression. I am not going to discuss the individual, disease manifestations. For example, factor 8 deficiency, factor 9, 11 deficiency. But in general, we follow a scheme. We have to give steroids with or without cyclophosphamide or rituximab or IVIG or plasma exchange. So I have come to the end of my discussion. So that's all about all the formed elements of blood in SLE, and also the plasma, which contains the clotting factors. So SLE can affect all the formed elements and the plasma, that is the clotting factors inside the plasma, and produce a myriad of manifestations, and the treatment of which differ and also sometimes overlap. Thank you.
Thank you, Dr. Tanvir. It's a very good and splendid presentation. Now, this is the session of question and answer. There is a problem here. I found only, I don't know what happened in the chat box. The actual question is only one question I am finding. Others, actually the comment. The one question to Dr. Asad from Dr. Nabil. How can I diagnose IHA in a patient taking steroid due to other reasons? Dr. Islam.
Thank you, Dr. Nabil, for your nice question. When a patient taking steroid, then the picture of the autoimmune hemolytic anemia may be changed. If patient respond with the steroid, then even the parameters may become normal. And if the patient does not respond adequately, then we find the findings before steroid started, such as low hemoglobin, spherocyte in PBF, high reticulocyte count, and raised indirect bilirubin. And one thing is, if patient already started steroid, then direct Coombs test may become negative, which is usually positive in autoimmune hemolytic anemia patients. Sir, I think if the other panelists can add something.
I think it's okay. I think sometimes it could be challenging, but I think what Asad said is okay. And if Nabil is not satisfied, he can ask any other points if he wants to know.
Okay, since Asad, there are not many questions for Asad. May I take the opportunity of asking him 2 questions? Actually, Minhaj, I think you have seen in ACR congresses, it is said, the chairpersons are requested to prepare 2 questions from beforehand to ask the presenters, So I have 2 questions to Asad. Asad, can you hear me? Asad?
Yes, sir.
Okay, I have 2 questions. First one is, regarding the treatment of autoimmune hemolytic anemia, you have said
Yes, sir, I hear.
the dose of rituximab, you have mentioned 375 milligram per meter square weekly, that is okay. But then I don't know whether it was my illusion. I also heard that you said 100 milligram weekly for 4 weeks. Am I correct in hearing? That is my one question. And the other one is regarding microangiopathic hemolytic anemia. You have mentioned spherocytes. Should it be a spherocyte or schistocyte?
Spherocytes are,
Thank you, sir. Regarding first question, rituximab usual dose is 375 milligram per meter square. But if the patient's body weight is less or other contraindications, the dose may be reduced to 100 milligram per week for 4 dose. Sir, it is probably I found it in up to date.
Okay, thank you very much. Thank you.
And sir, the next one is it is schistocyte. In microangiopathic hemolytic anemia, there is intravascular hemolysis, and intravascular hemolysis we usually found cystocytovascular hemolysis organ.
Okay, thank you very much.
I would like to supplement. I would like to supplement because actually there may be microspherocytes. When there is microangiopathic hemolysis,
There are, Dr. Ahmed,
Sir.
if there
Sir,
are
another
less questions,
Sir,
then
yes, sir.
we can also take the opportunity. Okay, go ahead if you have one question. Okay.
Sir, one question for Asad. Dr. S.M. Ahmed wanted to know, is there any role of steroid for becoming Coombs test negativity?
Thank you, the questioner. After using steroid, Coombs test may become negative, but it will not always happen.
You mean it may not happen always?
Question is different so far. Is there any role of steroid in case of Coombs test negative?
Negativity. Yes.
Negativity. Is there any role of steroid when Coombs test is negative? Question is very much clear.
It means, in Coombs negative autoimmune hemolytic anemia.
Yes, sir.
Sir, in autoimmune hemolytic anemia, whether it is Coombs test positive or negative, there is role of steroid.
No, or he wants to know if a patient is taking steroid, corticosteroid, and actually the test should be positive, but it may become negative or may be converted to negativity. Is it the question, Ahmed?
Yeah, I think this is the question, sir. But
Yes.
I want to clarify it. Dr. S.M. Ahmed, can you answer it? What you actually wanted to know? Dr. S.M. Ahmed, is the answer is enough?
We can't
Okay,
hear.
S.M. Ahmed. Okay, sir. I am seeing that chat box is empty for Tanvir Hassan.
I would like to supplement Asad's answer because sometimes there may be Coombs test negative autoimmune hemolytic anemia because the antibody concentration may not be high enough to produce a positive Coombs test. But in those cases, we have to treat them as just as in the same way as Coombs positive autoimmune hemolytic anemia. So it may be Coombs negative due to steroid, or because the patient has been getting steroid for some other reason, or it may be negative without the patient. It occurs in less than 5% cases.
Yes, so sometimes it may be confusing. Actually, he wanted to know, Ahmed wanted to know that it is due to autoimmune hemolytic anemia, but there may be a false impression when patient is on steroid. That's why he wanted to know it. I think so. He is not here. Okay, Professor Syed Atikul Haq wants to.
In fact, Ahmed, there are two questions for Tanvir. Yeah. If you scroll to the bottom, there are two questions by Manal Rahman for Tanvir.
Yes, sir. I found just now. For Tanvir, please answer it. What may be the treatment for immune thrombocytopenia, which has been diagnosed incidentally in pregnant patient? And how, another question, how will I treat a patient when thrombocytopenia 5000 with no active bleeding?
Okay. Both of them are very, very nice questions. Thanks to the people, doctors who asked these questions. I'm going to answer the first question now. If one is pregnant, so we have to give drugs which are safe during pregnancy. So we can use if there is indication of treating thrombocytopenia. That you have to check whether there is an indication or not. And first of all, and also we have to ensure whether this thrombocytopenia is due to pregnancy. Thrombocytopenia due to pregnancy. Pregnancy itself can give rise to thrombocytopenia. But in that case, the patient's lupus will be silent otherwise. And if it is due to lupus itself, then we have to treat it, and we have to treat it when it is less than 30,000. And in pregnancy-induced thrombocytopenia, it will never be less than 30,000 unless there is HELLP syndrome. So that's a totally different context. So I'm now coming to the context of SLE with pregnancy leading to thrombocytopenia. So we have to first ensure whether this thrombocytopenia is due to SLE or not. So if it is due to SLE, and if the count is less than 30,000, we have to put the patient on a corticosteroid with or without azathioprine. It depends on the context of the patient, clinical context.
In fact,
thank you.
Tanvir, I think you have noticed that in the EULAR 2019 recommendation, though they have mentioned the names of mycophenolate mofetil, azathioprine, and cyclosporine, they have added one point that among these three, the cyclosporine is the least myelotoxic.
Yes,
and if cyclosporine is least myelotoxic, in our country, we may have reasons to prefer cyclosporine to azathioprine, and cyclosporine is also non-teratogenic. So I think, we can use cyclosporine also instead of azathioprine.
So yes, sir. Yes, sir. You're right, sir. But the one problem with cyclosporine is that we might need to use this for long because if thrombocytopenia is, just we depend on steroid, it might take 2 to 3 years for us to reach a plateau state when we don't require any drug. So sometimes some patients might develop renal chronic interstitial, kidney disease, and chronic interstitial nephritis due to cyclosporine. But azathioprine, from that regard, is safer. So that's why I mentioned azathioprine. But yes, cyclosporine is also a good choice.
I think, Tanvir, this is a very much practical questions, and on many occasions we encounter this kind of problem. And now I am encountering a patient, the pregnant woman is like 2.5 months, and her platelet is decreasing and decreasing. And the last report I saw, it is 20,000. So, it's really a challenging scenario. Putting her on and lots of steroids also challenging, other than ESA or cyclosporine is okay. So
We
you
might
know
need to
these,
use IVIG as well, sir, in those if the patient can
but
afford.
you know it's very expensive.
Yes.
So in every case you cannot use it.
Yeah,
It's
IVIG
a
is
big challenge.
almost almost unusable in Bangladesh. Okay, I have got two questions for Tanvir. Number one is, you have mentioned regarding both neutropenia and thrombocytopenia. Viral infections may cause both neutropenia and thrombocytopenia. Is there any virus which may cause persistent, cytopenia for quite long term? For example, I came across in some literature that cytomegalovirus may cause prolonged neutropenia. And as far as I remember, herpes virus possibly may cause prolonged thrombocytopenia. And so, from this, I have another corollary that, should we investigate for any virus in patients with refractory cytopenias? That is my main question. And the second thing you have mentioned about bleeding in SLE, and you have shown several, factor antibodies, clotting factor antibodies, but possibly factor 7 is not mentioned in your list. Are you aware of, a special subtype of antiphospholipid antibody syndrome in which bleeding, there is a greater propensity to bleeding in addition to thrombosis, and these patients are often found to have antiprothrombin antibody.
Yes, sir.
Do you have any comment on this?
Yes, sir. Sir, actually, before answering to your question, I actually forgot to answer the second question that was asked to me. May I, sir, answer that question first and then move on?
Yeah, of course. I don't, I don't bind. I don't put any binding on the sequence of answers. Yeah.
Thank you, sir. Actually, what the question, second question was, what is the management of platelet count less than 5,000 due to ITP and the patient has no active bleeding? In these cases, even if there is no
in pregnancy proceeding,
Okay.
he added in pregnant patient.
In pregnancy, okay, sir. In this case, as the platelet count is less than 30,000, we have to treat it. And as there is no active bleeding, we don't need methylprednisolone. It is not mandatory to put the patient on methylprednisolone, methylprednisolone, but we have to, I think in this case, we have to put the patient on 1 milligram per kg of oral prednisolone first with azathioprine or cyclosporine A, and then treat accordingly. And we have to monitor the patient's platelet count frequently, so to track whether the patient is responding to it or not. And if the patient is pregnant and the platelet count is not responsive to our treatment, then IVIG is an option. Otherwise, platelet transfusion followed by splenectomy, if the patient cannot afford, has to be done because there is no other safe alternative in pregnancy. But if the patient is not pregnant, we can switch to rituximab very easily. And now I am going to answer to the first question asked by Professor Syed Atikul Haq, sir. Sir, actually, whenever we try to investigate a patient with ITP, meaning immune thrombocytopenia, recently the term has been, ITP means not idiopathic thrombocytopenic purpura, it means immune thrombocytopenia, whatever the cause is. So we have to actually, it's true that we have to thoroughly evaluate not only for the presence of anti-cytomegalovirus antibody, anti-herpes simplex virus antibody, but also anti-hepatitis C virus antibody, because that can also produce immune thrombocytopenia. Prolonged low platelet count, and also Helicobacter pylori. Helicobacter pylori is also a recognized cause of ITP. So there are multiple other causes, including viral infections, bacterial infection, H. pylori. It would be ideal to screen the patients, especially when the patient is refractory to treatment. And sir, the second question was, so can you repeat the second question?
About, antiprothrombin antibody.
Yes, sir. So actually, I mentioned it indirectly. APS usually produces thrombosis, but in the next section, I mentioned that there are several factors against which autoantibodies are formed, and the second factor was factor 2. So actually, sir, factor 2 is prothrombin. Prothrombin is factor 2, sir. So that's why that section also includes a variant of the APS that produces hemorrhagic manifestations, and that can also be treated with immunosuppressive therapy, sir. And unlike other APS, where we do not use immunosuppressive therapy except for catastrophic APS, this variant of APS may require immunosuppression if the hemorrhage is severe, in addition to control of bleeding with FFP.
Can I ask one question in context of Atik sir's question regarding cytomegalovirus? Dr. Tanvir, you have mentioned lymphocytopenia, absolute lymphocytopenia less than 1,000. You know, one of the important causes of autoimmune, and another cause is viral. And when lymphocyte count is very low, and sometimes we have to prescribe prophylactic PCP pneumonia for PCP pneumonia, cotrimoxazole. And can you tell me, is there any association PCP and cytomegalovirus? When you consider this patient might have PCP pneumonia or pneumocystis jirovecii infection, in that case, there is an increased chance of cytomegalovirus infection, and should you check strongly for cytomegalovirus antigenemia or antibody?
So if the patient, sir, can you please repeat your question? Actually, I think
my question is, when patient is suffering from very low lymphocyte count, and in that case, we consider PCP pneumonia prophylaxis, cotrimoxazole for pneumocystis jirovecii. In that case, do you know, is there any chance, increased chance of cytomegalovirus infection? If we think there is an increased chance of cytomegalovirus infection, in that case, we have to, should we check cytomegalovirus antigenemia or any antibody for cytomegalovirus?
Okay, sir. If there is increased risk of PCP, actually there is no standard guideline that mentions that PCP prophylaxis is required, because there is lack of high quality data. But it has been recommended by one authority that if there is, we think that there is a risk of PCP, then we will, we might provide. You know, it's not a very, not a very strong recommendation. So if we think that, if we think that there is a risk of cytomegaloviremia, then we might we might not prescribe it.
Okay, there is one line written in our up-to-date that when a patient, SLE patient suffering from PCP, there is an increased chance of cytomegaloviral infection, and there is the association in that case PCP and cytomegaloviral infection. We have to check. Another question to Dr. Tanvir, please. You have mentioned ASLS, macrophage activation syndrome. In that case, some patient having GIA and very young, or 6 years or 10 years old boy, suffering a typical feature of ASLS, like fever, high LDS, TG, or other factors. But the bone marrow finding repeatedly, there is no macrophage, but no lymphocyte like that. That we usually confirm. And you mentioned that this is a very much practical question for me. You mentioned the dexamethasone, etoposide, and the dose, you know, dexamethasone dose first week, second week is very high, and etoposide dose is also high. And this is a toxic drug. Can you think any customized dose for this patient when bone marrow findings is very much clear? There is no macrophage like that for diagnosis of ASLS.
So actually, diagnosis of HLH does not always depend on the finding of the macrophages in the bone marrow, because that's why we depend on criteria, diagnostic criteria or classification criteria. Because if you see the criteria, there are many other criteria. If the patient fulfills those criteria, and we can call the patient as having, we can tell that the patient is having hemophagocytic lymphohistiocytosis. So the presence of if we have a very strong suspicion, pending the bone marrow report, we can start the treatment. That has also been mentioned in up to date. So pending the report, we can start if we have a strong clinical suspicion, because it can lead to grave consequences. So and presence of demonstration of macrophages in the bone marrow may not always be possible, because the involvement is not homogeneous. It may be patchy. So if the clinical suspicion is very high, then we have to go for treatment. But I don't know, sir, any customized dose, because everywhere it has been written the HLH 94 protocol. So I don't know actually about any customized dose.
So far, written in up to date also. Recently, I didn't go through. If we we didn't found any macrophage in the bone marrow repeatedly, in that case, we may avoid etoposide and we may start only dexamethasone because etoposide is highly toxic.
Okay, Shaheen. So we have another 2 overseas participants from Sri Lanka, other than Nepal, Dr. Bineet from Nepal, and I have seen 2, Dr. Duminda and Dr. Kalum. I'm not sure whether they are still here or they have left. Dr. Kalum and Dr. Duminda, still, I think they have left. Anyway, we could listen to them if they are here. No. So we have some senior guests also today. They have participated. Professor Mohammad Ismail Patwari, I can see. Professor Khan Abul Kalam Azad too, and Professor Brigadier General Abdul Alim. So welcome to all of them. If they want to make any comment, any supplement, I think they should take the floor. Professor Ismail Patwari, would you like to make any comment here? Anyway, so I think we can listen to them again. I have just one question. It's too much questions, really. So I just wonder regarding the thrombopoietic agonist, receptor agonist, Tanveer, especially L-thrombopeg is available in our country, and I am not sure the other 2, Eva thrombopeg and Romiplastim, I think these are not available probably. So if we consider this drug, because in this challenging situation, sometimes we need to switch over one after another in thrombocytopenia or treatment thrombocytopenia. So for how long we need to continue this drug is again costly, expensive, and for a prolonged period of time, it is required to continue. So that is another challenge, L-thrombopeg also to be continued. So would you like to make any comment for how long?
Sir, actually, there was a trial. There was a trial with oral glucocorticoid in patients with ITP. So in that trial, the result finding was that at the end of 2 years, the patients who responded to glucocorticoids, majority of them could be, rescued from glucocorticoids. So that was the trial on the basis of which prednisone used to be prescribed alone. So it can be then inferred from this trial that it might last for years. So there is no consensus on how long we should continue this. So, but on the basis of that trial result, so I can reach a corollary that we might need to put the patient on that treatment for at least 2 years, and then we can lower the dose and see whether the platelet count falls again. And if the patient count does not fall, we can taper it off. So maybe it's 2 years, because according to that trial data.
Yeah, there are trials, but you see, whenever we stop this drug, platelet again goes down. So
Yes, sir.
it needs
So it
to
should
be
be years together,
continued
sir.
for a prolonged
2 years at least. Yes, sir.
That's a challenge to problem.
Sir, only one question remains from the participant.
Arshadul Azim,
Does that time permit, sir?
Yes. Just one question.
Dr. Arshadul Azim wanted to know the management of hypoplasia or aplasia in SLE from Dr. Asad. Dr. Asad, can you answer this?
Anyone can answer.
Or
anyone from
the speakers?
Okay, Asad, go ahead.
Thank you, Dr. Arshadul Azim. Hypoplasia or aplasia in the SLE usually in the form of pure red cell aplasia. It is usual, but it is not so common. And we can treat this pure red cell aplasia with glucocorticoid for 4 to 6 weeks, and steroid sparing agent may be used with cyclosporin or cyclophosphamide can be used for treatment of this patient. So, from me, it is if any panelist want to add something.
Actually, can I talk? Actually, hypoplastic anemia or diminished all three cell line is not common in SLE. Already, ATM Tanvir mentioned. Usually, we find thrombocytopenia, anemia isolatedly. At a time, three cell line goes down, aplastic anemia is uncommon. When we found a patient of SLE suffering from all three cell line, diminished all three cell line, we should think other causes like leukemia, pure aplastic anemia are not due to SLE. So may happen, but in that case, we have to consider other cause of aplastic anemia. Thank you.
Okay, Dr. Azim also wanted to know if the patient is on steroid, whether you will if steroid refractory, what will how will you manage the patient? If the patient is refractory to steroid, the patient is already on steroid.
Is this question to Dr. Tanvir or Dr. Asad? Okay, Dr.
No,
Tanvir, go ahead.
Dr. Asad.
Sir, then if patient not adequately respond with the steroid, then we can add cyclosporin or cyclophosphamide in this patient.
Okay. Okay. There is
also we can also consider MMF, but I think as the patient has based on this question, as the patient has suppressed cell lines and cyclosporin is least myelotoxic. Cyclosporin is least myelotoxic. I would go for cyclosporin.
Okay.
Yeah, clinician's judgment would be important in this scenario. Okay, Ahmed, yes, we should try to conclude because
okay,
we are approaching
too
to
late.
12 o'clock.
Now, I am going to the comment on behalf of the panelist.
I think Dr. Bineet, if he wants to make any comment on these questions, he can.
Okay, we want to know some comments from Dr. Bineet Vaidya, please.
Yes, the presentation was very excellent, and the discussions were. It was very interesting as spellbound listening to all the discussions. As just one comment on the issues of the PRCA, we had encountered one such case. We were managing as lupus with. He had all features of lupus, DHTNS positive. He was responding well for the initial few years. When he had developed anemia, which was refractory recurrent. Recurrently, he used to take transfusions. Yeah, after bone marrow aspiration, we diagnosed it as PRCA. It was very rare, but then after diagnosing PRCA, we were preparing for a bone marrow transplant. It was in the early COVID period last year when he was diagnosed. he was being prepared for a bone marrow transplant for PRCA, but at that time he suddenly developed erythema nodosum and swollen tender earlobe. After that, we made a diagnosis of relapsing polychondritis, which was secondary RPC developed in a patient with lupus, and they preceded with refractory anemia. So as Dr. Sahin highlighted, if it is persistently abnormal, or if there are other cell lines involved, then not only secondary causes, infections or malignancies, we should also think of other autoimmune diseases that might coexist with lupus, and which we really get biased when we are seeing the same patient for a long time.
Thank you.
Okay. Thank you. Now I like to invite Major retired Dr. Jamil Abdal to give his comment, please.
Thank you very much for allowing me to be here by Bangladesh Rheumatology Society. Both the presentations are very nice. I just mentioned 4 things which are practically required. Number 1 is we have to educate the patient very elaborately so that they don't miss the follow-up time date, because many times the active disease and the drugs may cause these some sort of hematological cytopenias. And secondly, we have to take a good history which regarding the drugs, even the naproxen, aceclofenac, these drugs may cause thrombocytopenia. Sometimes recent infections may cause some cytopenia. So the history is very much important. And another thing I would like to mention that now it is not recommended that in case of anemia of inflammation or anemia of chronic disorder, we should try the patient with intravenous iron, because oral iron in inflamed condition less absorbed. And thirdly, one thing we should remember that in case of acute ill patient suffering from severe cytopenias, we should concern a hematologist, our hematologist colleagues, which has not been discussed here. Thank you very much.
Thank you. Now, may I invite Dr. Mohammad Abu Shahin for his comment, please.
Thank you, Dr. Ahmed Bhai. I already participated in question and answer session. So briefly, I just like to thank all 2 speakers, Dr. Asad and Dr. Tanvir, because they nicely and presented the topic. This topic, hematological manifestation of SLE, this is very commonly encountered problem in our hospital practice. Dr. Asad nicely presented about ACD, anemia of chronic disease, autoimmune hemolytic anemia, and Dr. Tanvir also touched all the corner of today's discussion. So I again thanks both the 2 speakers and the main organizer Minhaj Rahim Chaudhary sir and Ras TV for today's program. Thank you.
Now, may I invite Dr. Shamim Ahmed to give his comment, please. Dr. Shamim Ahmed, I've seen a few minutes ago. Dr. Shamim Ahmed left the webinar. Sir, may I invite Professor Minhaj Rahim Chaudhary, Professor of Rheumatology, DSM. Sir, please unmute yourself.
Dr. Bineet will tell after me, or we
okay,
need to listen to him, Dr. Bineet.
Okay. Yeah. Yes, sir.
Sir, indeed, everything is almost covered regarding the topic. I'd like to uh, regarding the discussion on the parenteral iron therapy, we have experienced certain cases of flare, especially in rheumatoid, sometimes in lupus, after parenteral iron therapy. I don't know how your experience has been in such cases. Maybe Dr. Tanvir can highlight on that. And otherwise, every other topic was discussed fluently, and the questions and answers was very brilliant. I would love to do sessions often. I'd be in touch with Dr. Sweta for the connection. I think I heard from her that these programs are very frequent. I'd like to join as audience silently. I'd like to thank Professor Atik and Dr. Mina sir for remembering me, and thank you very much.
Okay, sir. Professor Minhaj Rahim Chaudhary, please.
Okay. So, dear chairperson, panel of experts, moderator of the program, and learned audience, it is our 6th consecutive monthly webinar, and we are grateful to our overseas guest, Dr. Binit Vaidya. He has joined from Nepal despite his very busy schedule. And today also joined Dr. Dominda and Dr. Kalum Deshapriya from Sri Lanka. And unfortunately, we couldn't hear from them. We are also lucky to have some senior teachers in Bangladesh, Professor Khanabul Kalam Azad, Professor Muhammad Ismail Patwari, Professor Muhammad Abu Bakr, Brigadier General Professor Abdul Halim, and Brigadier General Shamim Haidar, I have seen, and from Bangladesh Rheumatology Society. We always welcome our senior teachers to participate in our these webinars, monthly webinars, and it will inspire us. I must thank two of our young speakers, Dr. Asadul Islam and Dr. ATM Tanvir Hassan, for their brilliant presentation. And Dr. Asad nicely highlighted the causes of anemia in SLE patients and how to manage, when and how to use oral and IV iron, when to use RBC transfusion, how to manage especially autoimmune hemolytic anemia, always is a big problem. And then Dr. Tanvir talked on thrombocytopenia and leukopenia, types of leukopenia and their management in detail, very nicely elaborated neutrophilic dysfunction, also lymphopenia, which usually we ignore. We encounter this kind of problems like mono, bi, or triple cell, sometimes, very rarely also triple cell line problem. So I am very much confident that all of us, especially I must say I myself have learned a lot from their deliberation, and it will help me to enrich my knowledge on this particular subject. We are thankful to our scientific partner, Delta Pharmaceuticals, and special thanks to Mr. Adnan and Mr. Saiful, and our media partner, Raj TV, and special thanks to Dr. Vasudev and Mr. Rafi. So with these few words, I would like to conclude my talk. Thank you, everybody.
Okay, sir. Now, may I invite Professor Syed Atikul Haq, chairperson of this CME. Professor Syed Atikul Haq, sir, please.
Okay, thank you very much. আচ্ছা নজরুল ছিল না, নজরুল নামও তো বলছিরা?
No, Nazrul did not join. He was a chairperson, panelist, panel of experts.
Okay, thank you, dear colleagues, organizers, panelists, including particularly Binit and the speakers. I thank Asad and Tanvir particularly for their excellent presentation. They have prepared their talks with great care. And actually, I have also learned many things, and I had the opportunity of clarifying some of my confusions. Though actually, I wonder on one issue that, why Kikuchi's disease is no longer mentioned as a part of systemic lupus erythematosus. We had come across quite a good number of Kikuchi's disease or Kikuchi's lymphadenopathitis in patients with SLE. Though actually, it doesn't make any difference in the treatment. That's true. But even, if we don't say anything about Kikuchi's, maybe sometimes some of the rheumatologists may also wonder why the pathologist has reported Kikuchi's or necrotizing lymphadenitis. So I wonder, even up to date, the Kikuchi's has not been included in up to date also in the lymphadenopathies associated with systemic lupus erythematosus. And I should also emphasize one thing, I find among our doctors, including, many internists and also sometimes rheumatologists, they feel very much tempted to treat mild to moderate thrombocytopenia with immunosuppressive treatment, and also get very much alarmed when the absolute neutrophil count is below 2000 but above 1000. And I think from today's lecture, it has become very clear to us that, we need not worry until the platelet count is less than 30,000. Even we don't need to, add any immunosuppressive treatment if the patient is not symptomatic. And at the same time, we need not worry much about when the patient has got neutropenia with ANC above 1000. Of course, if ANC is above 1000 and if we find that some drug is culpable, we have to try to reduce or eliminate that drug. That is the thing. But we need not get so much alarmed as we often happen to be. So actually, these are the things. And also, I thank the participants. The participants have adhered to the program for quite long period. I have found that, just before 10 minutes, the number was 65. So that was quite amazing. And also for very much active participation of the, of the participants. And that proved to me that, Asad and Tanvir have been very successful in drawing attraction of the, participants. And finally, it will be my ingratitude if I don't pay my, thanks to Delta Pharma for the scientific partnership and also Raj TV for the media partnership. And with these few words, I conclude my talk. Thank you very much.
Sir, please close the session. Sir.
Close money, I'm close to it. Okay, then
yes.
I declare closer of the session. Thank you all. Thank you very much.
Thank you.
Thank you.
You are watching Raj
So we are
TV,
leaving.
Jagorone, Bangladesh. Please subscribe our channel.